defenders and prosecutors. What does the prosecutor think?
Falsifying documents.
Well, you're falsifying documents, this is an easy slam dunk case, there's a good chance I'm gonna win. Okay? Your attorney, who's trying to defend you, says, it seems to be happening an awful lot. I don't think I can represent you. Why not? You're making a medical error. You took an x-ray of the left shoulder when in fact it was the right side. Okay? Now back to practicality. If I'm looking at a shoulder that, and I looked at one yesterday, and there's no marker on it, you've been taught to mark every x-ray, correct?
Mm-hmm.
Okay, there's no marker on it. Now what has to happen? I get to call the office. Who's the person taking the x-rays? That person isn't in, okay? Nobody else is gonna take the heat for it, so I have to call back tomorrow. What's happening during all of this delay?
They're forgetting.
They're forgetting, but what about the treatment?
It's untreated.
Yeah.
Yeah.
I'm not gonna treat a shoulder, I don't know which side it is,
Right.
okay? Now let's take it back to the spine. Is it important to know where the block vertebral body is?
Definitely.
Okay? C3 versus 5-6, is that important to you?
Yes, sir.
That's why we have the anatomic location, okay? And the rubric. All right, so I'm using that one. I don't know why that's empty, it doesn't matter. What I want to show now. What view?
AP.
Okay, so in your search pattern, okay, there's the odontoid, there's the posterior neural arch of C1, okay? There's a gap here, yes?
Yes.
Okay, which side's the gap on?
The left side.
Left side. That's a bad way to lose either half a mark or a whole mark, okay? I don't know, I've got the wrong slide, wrong PowerPoint in here, there should be 5 cases. What's the abnormality of the U first?
Lateral view.
what? Okay, good. Now, what's this? Anatomically?
That's anterior
Anterior tubercle of?
C1.
C1, good. If you thought this wasn't a space and you thought this was occipitalization, I have no problems with that. It didn't hurt you, it didn't harm you, okay? What's happening between C2 and C3?
It's a block.
Why is it a block?
Spinous processes are fused.
The spinous processes are fused, okay? And there's a little bit of an anterior wasp waist, all right?
Concavity.
And then on the other version, I had a block vertebral body that had no facet joints. This
Yep.
is anterior portion of the vertebral body. There's a remnant disc, anterior concavity, so I'm giving you all the radiographic findings we discussed in class. You had to decide, where's the joint space between C2 and C3?
There is
It
none.
should look like this.
Right.
And if you thought, or you kept going, this is the normal interspinous distance between the spinous process of this mess, the block vertebral body, and C4. Okay, so I want you to go all the way from the front to the back. Not because I think that's a neat thing to do. What did we talk about block vertebral bodies? If you have a space between the segmentation defect or the block, you might be able to manipulate, but when it's fused from the facets back to the spinous
Can't manipulate.
processes, you can manipulate, the patient's never coming back to your office because you created soreness, all right? Now, the practicality is, if you're not sure of this, if this is a patient that you take an x-ray of and you're not sure whether this is a block vertebral body or not, what did we instruct you to do?
Don't manipulate.
Don't manipulate.
Flexion,
Flexion.
extension.
If this separates and this separates, the block vertebral body doesn't involve. But if there's no separation, so you've either a positive outcome or a negative outcome, depending on how you want to describe it.
Yeah.
Okay? So part of this is what we're learning in class. On this side, we're teaching you, but when it's the cases, and the reason I use the cases every time, you're the ones that are going to be interpreting the x-rays when you're a graduate doctor, okay? We're not saying you need to be a specialist in MRI, we're saying you need to be a very good discriminator of the x-rays that you took, okay? All right. Well, let me go back and see if I can salvage where my cases are. Okay, let's do it this way. You'll see some similarities, you'll see some differences. So the review is good. Okay. Where's the, what's the view first?
Lateral,
Lateral?
cervical.
Good. Where's
sorry.
the abnormality?
So
C1,
What's happening at C1?
arcuate.
you have your arcuate
Arcuate
foramen,
Okay? Now, notice,
also
see, this is C3. Notice the soft tissue space.
Yep,
Okay? If we ask the question from the written, what should the normal value be at C3?
7, sorry.
7. Okay? 4, 5, 6, 7. What should the value be here?
21,
21. And then I added, I said the mid-cervical spine, roughly what? If you didn't write it down previously, write it down now. 5
5
millimeters, plus or minus, okay? We don't have to get into age and sex matched individuals. Okay, in terms of your search pattern, is this image showing me a sella?
Yes,
Yes, it is, okay? What are the numbers for the sella?
8 and
8
16.
and 16, okay? There's a reason we talk about this stuff. On this case, I see it, all right? You'll go a long time looking at cellas and you'll say, I don't have to measure it anymore. But when this space is increased, you have the beginnings. It's a mass thing, something, that little pituitary gland inside is getting bigger and bigger and causing this separation, all right? Next one. What type of images?
Oh, lateral,
Lateral, lateral,
cervical, sorry.
cervical, okay, lateral in our world, lateral, and this is what?
AP,
AP or coronal, all right? So now, I get an anterior tubercle, I get a posterior
Posterior
tubercle, this is foramen magnum. Is there another ossicle here that shouldn't be there, or should be morphologically different? Yes, this should be attached to this body.
yep.
So what do we have?
Osodontoides.
Osodontoideum, okay? And I don't know if I did, but I'll deliver an osodontoideum to the Instagram side of things. You'll see an osodontoideum when we do our cases, okay? May not necessarily put an osodontoideum on your next set of written cases, all right? Now, this is not a cervical examination, this is a CT scan, and we're just introducing the idea. It doesn't matter whether it's a plain film, a CT, or the MRI. The fact is, where this arrow is, this is space. This top of the dent should be attached to this. Now, we all know how to take an AP open mouth view, right?
Yes,
Why is that important? Because we need to be able to see the odontoid from the AP perspective as well as the lateral. If it's a common fracture site, when your head hits the steering wheel, it's important that you have good x-rays of it. Does that make sense?
yes.
You saw that one? I remember showing you, there's the cartoon diagram here with a small one. This just happens to be a big, an example of a large spina bifida. And I was hoping you would all would see it, and I recognize that it's on the left side. Okay, the block, what are we showing you here?
Cervical rib,
Cervical rib, which side is greater?
left,
Left. And then the next level of sophistication or education is the side that's longest. There's usually a fibrous band that connects this to whatever it's going to connect to. Thoracic outlet syndrome, okay?
Mhm.
If your patient has this, it may take a while, but if they start having pain into the arm, that needs to be evaluated. We evaluate it with an MRI, all right? The longest one I've seen in clinical practice from here to here, 7 centimeters. How many inches? 3, okay?
Mhm.
So, example of the cases, not the ones. I can definitely show them to you on some other time, but you get the idea. Okay, let's see how this works.
So in future cases on the exams, you just want us to sit there and go, lateral cervical.
Well, on that example, I'll usually say type of exam, okay, I may not have said that, but where we're headed with that whole concept, Jeremy, is when you do a RAD report, there's gonna be a section on that says technique, meaning what views were taken, okay? So we're starting with our projects, we're starting and saying, okay, might as well get those views in order, let's get that done. And right now, I'm saying you get a mark for a normal variant, the level of the abnormality and the name of the normal variant. Okay, and that's consistent from here on in. So let me ask you a question. The people down the next classroom, semester 8, what do you think they forget when we do a project?
The view.
No, not the view.
The type of, the name
The marker.
of the area.
You'll study a disease process called diffuse idiopathic skeletal hyperostosis, DISH. Okay, it's of the cervical spine. Is it important to know what level the cervical spine has it with DISH? It could be from
Yes.
C2 to C7, it could be some 3 to 6. But the important thing is, in that condition, the posterior joints are clear. So in your search pattern, if the posterior joints are clear, what does that mean to you clinically?
If the posterior
manipulate or
joints,
not
you
manipulate?
can.
You can.
Yeah.
Okay? Similarly, if the posterior joints are fused like a block vertebral
You
body,
can't.
should you manipulate?
No.
No, you can't even mobilize, in my humble opinion, because it's one ossific mass. Okay? So, we try to introduce the whole concept of how important the level is, do the surgery on this leg, not this one, okay? But by the time they get to semester 8, all right, they tell me what the disease process is, they don't tell me what levels, and they don't tell me whether it's mild, moderate, or severe. If you have a severe something, degenerative disc disease with degenerative joint disease, would you treat that patient the same way as a robust, young 20-year-old male?
No.
You can't. That elderly patient has severe degenerative joint disease that affects your treatment, I would think, I would hope. That's the reason you're looking at the x-rays and saying, I'm not worried about the posterior joints, they're all normal. Does that make sense?
Yes.
So those kinds of concepts that we introduced right here at the beginning, that's supposed to follow through. Now, one of the reasons I do it is when you get in front of a national board, part 3, where there's cases, x-ray cases and information, you get 2 minutes. Okay, that's a lot to digest. But by that time, we've practiced enough, views, no big deal, level, no big deal. Okay, you can answer the questions intelligently because we've done it enough times. But if you aren't used to that, just like how comfortable did you feel about taking an x-ray when we first started?
Not at all.
It was difficult, okay? But now we're getting a rhythm to it, all right? We're getting a technique. We may change some of our things. I have no problems knowing and saying that you'll take good x-rays, unless after graduation, I'm the doctor, the switch goes off, and I can do whatever the hell I want. Yes, you can, but it's your liability, okay?
Yes.
And I'm not one to throw you under the bus, okay? If I'm an expert witness against you in court, it's not gonna get there. But I'm gonna say to the attorney, that's not how they were trained. Okay, if we can associate some student with whatever that thing is, that's 5 years down the road, okay? You've been trained well, you wanna maintain that and take it to the next level. Okay, can you do that with everything? No, not necessarily, because you don't have the supervision. But when you leave here, you're here. You need more practice with manipulation. That'll come treating 20 patients a day, right? I mean, that's a skill that will develop rapidly. But some of those things, gonadal shielding. You told me what you saw when you were being x-rayed. That's what you're up against. You want to stand out from the crowd. Okay?
Mhm.
So understand that there's a process from semester 5 class to semester 8. And semester 8, why did I lose a mark? Well, did you tell me about the level? No. Did you tell about severity? No. And you're complaining to me about your grade? No. It doesn't work that way. Okay? Is it important to know a block at 2-3 versus 5-6? Yes. And when the insurance company gets your report, they say, okay, this is no problem, we have no problem reimbursing. Once you get the reputation that from this clinic, they do stellar work, you're not gonna get denied, okay? Because they're keeping track. All right. The big thing to understand is everything starts at the filament. Which side is the filament on? Cathode, good. Everything starts there, okay? It's like the toaster being turned on, all right? Field size is, I keep telling you, have a,
Perimeter.
a perimeter, a frame around your rectangle, right? Okay, a picture frame, sorry, all right? Characteristic radiation happens in the area that has tungsten. Which side has tungsten? Anode or cathode?
The anode.
Anode. At that point, it's characteristic of the tungsten in the anode side, okay? The
Mhm.
focusing cup, when they have enough electrons on the filament side, those electrons are repelled over towards the target, okay? The primary purpose of the filament is to create the electrons. Ionization doesn't happen until everything hits the anode, okay? Anode Hill effect, remember that statement, that picture?
Yeah.
Okay, that was asked on the last board, okay? But it wasn't asked about the anode Hill effect. It was something called the line principle, where the electron beam enters the target, and it was pretty big, and then as it exits the machine, it became smaller. Remember that picture?
Mhm.
That's what they asked about. Who the hell cares? I don't care, okay? I didn't emphasize that. I emphasized the fact, the anode Hill effect, and in the picture, the intensity of the X-ray beam is larger on the lumbar spine because it's a larger body part, okay? All right, characteristic radiation, where's the tungsten again?
Anode.
Anode, good. Which is a true statement regarding collimation, it's, okay, I think we all
Reduces
agree it's not this
exposure.
one, right? Does it increase exposure to the patient?
No.
No, the whole idea was, or is, reduce. And then we said, what does collimation do for you? Does all those things, okay? Decreases exposure to the patient. What does it do for your AHARA?
Makes it good.
Increases it.
Okay? And you haven't spent a dime on any new equipment, you're just using the equipment that you have, okay? There's a picture in your notes, the types of radiation, yes? I know
Yes.
there is. Characteristic radiation is inside the tube, okay? But secondary radiation is what comes
Scatter.
after, when the X-ray beam comes out of the glass envelope or the window, all right? Leakage, you need to know these types. Primary is what is directed towards the patient. There's a green color there, right? What does that mean again?
You're gonna see it again.
You're gonna see it again in some way, shape, or form. Okay? We talked about this, I showed you the example. Now, the reason you include this in your search pattern, when we get to semester 7, we talk about tumors, and there's a huge soft tissue mass anterior to the mid-cervical spine. Are you gonna be able to recognize it? Yes, because you're looking at that dimension. It should be fairly parallel, 7 millimeters anterior to C3. You're trying to get a feel, a mental picture of what the prevertebral fascia looks like, okay? The least amount of radiation. I've asked the question another way, which of these field sizes produces the greatest amount of scatter radiation?
14 by 17.
14 by 17. So what do we say? Picture frame, keep it small. Why? Because look, where's
Less
my spine?
exposure, right there.
It's still in the middle. Okay, now you can get crazy about the collimation and say, I just want the neck. Okay, that would work, all right? Because since I've been doing this since 1992, when I got my diplomate, not one doctor has ever asked me, I'm worried about this big soft tissue tumor. Hasn't happened yet, okay? The spine is in the middle. We try to use that to our advantage when we're taking x-rays. You just have to, okay, inherent, added, this should have been 1 for a total of 2.5 millimeters, okay? And the reality is your machines come with this built in. The only people that think it's important is national boards. So every time I say national boards, you should be making note of it, okay? Or someone should be tracking how many times I say that. I'm not trying to teach to the test. You will all pass your national boards. I'm worried about what you're gonna do when you're in clinical practice. Okay. So the target and the anode go together. That's the part that produces photons finally. Does that make sense?
Mm-hmm.
Okay. 99 to 1 ratio. So if the majority of this is heat, okay? All this is heat, you get a pencil-thin little beam to work with. What does that tell you? 1% is useful energy, but can you just sort of randomly say, I'm gonna aim at the hyoid cartilage? No, that's why you have to be as specific as you are.
Right.
Okay, everything has to be perfect because you only get this small little area to work with. Okay? And this hasn't changed, it's not going to change. It's causing so much heat that we have to work with what we have, which is a small percentage of the overall interactions inside the X-ray beam. I was surprised, okay, our right anterior oblique view gives me which IVF?
The right.
Right.
Okay? You just have to make sure, because we're entering lumbar spine country and it's different, okay? If you don't have this straight, okay, you're gonna mix up your lumbar spines, and then instead of having one wrong, you're gonna get both wrong, okay?
Mhm.
So, and the other thing I need to tell you is if you have a question, ask me. You know how to use that tool?
Yes.
Mhm.
Okay, if you're embarrassed, that's fine, come and see me individually, we don't embarrass you, but you have to get the correct answer. Now, why do you think that's important?
So that way you know.
Because of your report. You need
Your
to-
report,
Yeah.
okay, when's the next break? Whoever's shadowing gets an opportunity to take a break. I mean, take the opportunity to go shadow somebody, all right? And then just ask the chiropractor. But they already know if you ask them. I was just wondering, Dr. Borowski didn't explain it very well. You do anterior obliques in your office, correct? Okay, on a right anterior oblique view, which IVF do I see? If you get anything, then they're mixed up. Either they've forgotten, they don't care, all right? But I can tell you that the attorneys care, because if you give them right anterior oblique and it's not the right IVF, you're mixed up, your RAD report is correct, and everything dominoes. Okay? That's how important that is. And if the attorney says, sorry, you may want to find a different attorney, he's being polite and saying, you don't know how to, you're not writing your RAD reports correctly. Okay? Now, the first two cervical spine x-rays are done where? SID wise?
40 inches.
40. Which of them has a cephalic tube tilt?
The anterior.
Lower cervical.
Lower cervical. Why? Because you all have a lordosis, or we all have a lordosis. That's why you tilt the tube to get through the disc spaces. And the other reason we do that tilt is we see the uncinate processes.
Mhm.
Okay? So I just had to look for the correct answer, okay? I'm at 40 inches, 10 to 15 degree cephalad tube tilt, and I collimate. Okay? So the teaching point isn't that. The teaching point is the first two are done at 40.
Yep.
Everything else is done at 72. After you're done with your COVID mask, AP open mouth, everything is aimed at what?
Thyroid
Thyroid
cartilage.
If you can remember that, it's golden. The next thing I have to ask, or what I think of, does my x-ray examination I'm gonna do take a tube tilt? And in which direction? If you're not sure, the majority of them are going to be
Cephalad.
cephalad. Okay? It's all fine and good when there's no pressure, but when there's pressure, okay, you change your correct answer to the incorrect one. You're going to sort of go through it or whatever, okay? What is this?
Isotropic.
I know.
Oh,
Many
when it
directions.
scatters in all directions.
So X, Y, Z, okay, scatter radiation. That's why we have a grid, that's why we have a monitoring device to make sure there's no excess radiation other than the patient, but we want to expose the patient because we want to get an X-ray beam. What's heterogeneous?
When it's going at different speeds,
Not speeds, that was
different
my
direction, different, well,
intensities.
intensities, yes.
So let me ask you, if you were in a car accident, you want the car that hit you going 20 miles an hour or 80?
20.
20. And the comparison is, okay, the beam that's going 20 units of intensity is only gonna get to the skin. It's doesn't have the power to get down to the lumbar spine.
No.
So that's where I went from the turnpike to x-ray,
Yeah.
okay? All right, thermionic emission is in the cathode side, all right?
Heats them.
what does person's occupation, type of insurance, and everything else have to do with performing a
Nothing.
radiographic examination?
Nothing.
This is your long list, okay? And what the insurance companies want to see is, how did you justify the x-ray examination? That's your decision after you do a good history and a physical exam. So let's play the game. What else besides prior carcinoma is a justified reason for taking an x-ray?
Pain? Pain?
Pain? No.
Oh, fractures?
Suspicious of fracture. How does a fracture happen?
Trauma.
I know trauma, specifically how trauma? Well, you often have
Impact.
patients who, people who you've known have had trauma. Motor vehicle accident, what else?
Sports injuries,
Slip and
Sports
fall.
injuries such as
football, spearing. jockeying.
spearing,
Slip and
helmet
fall.
in the ribs, helmet in the
Question.
equestrian, okay? Elderly patients, what's wrong with elderly patients besides, what's
Balance.
wrong?
Osteoporosis.
Balance, okay, they fall where, how? On their butts. When they fall on their butts, can they fracture their lumbar spine?
Yes.
Of course, I'm giving you all the scenarios that you're going to be interacting with patients. What happens when I fall on an outstretched hand,
You can break it.
okay? Why would I want to x-ray Dorian? Now that I know a little bit about him.
Prior injuries.
Prior injuries. You have all kinds of reasons for substantiating why you took the x-ray examination that passes muster with the insurance company. There's no reason for them to deny. But when you say to rule out biomechanical alterations or pain, that doesn't cut it. That doesn't stand up in the medical literature, okay?
Mm-hmm.
So this is a long list. I tried to put in silly things that didn't particularly fit, okay? And this is what we want to rule out. And if your script says, I want to evaluate for a occipitalization, they all know what occipitalization is. You will not be denied. Now, I'm not saying we're going to spend all our time building this case, but yes, in fact, we are, because we want to be reimbursed, okay?
Mm-hmm.
The worst case scenario is they say, Dr. D doesn't do a very good job of scripting or documenting. We're gonna tell him that all the x-rays he's taken last year that we paid for, we want the money back plus interest. Ouch, the pocketbook, right?
Mhm.
And that can happen, okay? I don't want it to happen to you, let it happen to somebody else. Okay, suspected cholelithiasis, day one lecture. I emphasized what imaging modality? Diagnostic ultrasound. And auscultation is not an imaging modality,
Mm-mm.
right? Would you
Correct.
agree with that?
Yes.
Okay. On your search pattern, I'm giving you anterior concavity of a motor unit, remnant disc space. The word picture is what? What's that describing?
Block.
Block, okay? All the characteristics of a typical block vertebral body. Now, if you don't know what occipitalization is, we said what? Help me.
It's when the C1 is
No
fused
space
to the
between occiput and
C1.
C1 posterior neural artery.
neuron.
Okay, when does that happen? It doesn't happen, it happens after the car accident. Someone notices there's no space between occiput and C1.
That's how
What
they're
do we
born.
do?
Flexion.
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 Okay, and the next thing is, why do we want to do an MRI?
To see.
It's bony, but we want to see soft tissues.
Okay.
Which soft tissues?
The
Prevertebral, good, but more importantly, related to the occipitalization. So if they have an occipitalization, there's a likelihood that they have another soft tissue abnormality, the Arnold
Chiari syndrome.
word. Okay, now when they have the MRI, they may find all kinds of other soft tissue things. They may have a split in the cord, something called a syrinx, and there's a post-traumatic syrinx. I want you to get used to the idea there's complications after car accidents. All right? Now, tell me, if the patient, the RAD report comes back and says, yes, there is an Arnold Chiari, you don't care what type it is, but the RAD report says Arnold Chiari. Is that information useful to you? Absolutely. Okay? So now, all of a sudden, things get intense, because there may have to be a surgical intervention or a decompression to the upper cervical spine to deal with the Arnold Chiari. If, on the other hand, the report comes back, no Arnold Chiari, is that a good thing for you?
Yes.
Yes, you don't have to worry about it. You can sleep at nights. You didn't miss anything. And it's also good for the patient because they don't have to undergo the traumatic event of the surgical intervention for urinary care. Okay? What's possible agenesis of the posterior elements?
Cold exposure.
Cord exposure, there is no posterior neural arch.
Yeah.
And on one of the previous examples, I showed you the vertical split. And I'll try to find my versions that I actually use in the exam. You'll see it because it's just another normal variant. So it can be so posterior neural arch. Here's the posterior tubercle. It can be split, a small split, a big split, okay? Or maybe it's totally missing, okay? And we have terminology for that. So agenesis means it didn't form. I showed you an example over and over again where the posterior neural arch was totally missing. That's not the problem. The problem is they don't have any protection. They're at risk, okay? And you get to counsel them at risk. If you don't know what that is, when you're in clinical practice and I'm not around, you just Google agenesis of the posterior neural arch and you get all these hits on what to do and what not to do and what to look for, okay? All right. IVFs, we agree that this is the best view.
Yeah.
It is now, okay, and will be for a long time. Okay, the collimator, I started to need questions.
Bless you,
Bless
bless
you,
you.
you're touching it all the time in the lab. Do you really know where it is? You're touching it,
Yeah.
right? Okay, and then 20, I thought this was pretty straightforward because radiographic steps, that's a radiographic step, that's a radiographic step, that's a radiographic step. I didn't think this was a radiographic step, but I've had discussions already, sir, okay? But the majority of the people, when I did my review, okay, the most of the people answered the question to my surprise, the way I thought it might be answered, okay? So it's okay, you still got 99 out of 100, all right, it's okay. Okay? All right, so why did we spend so much time doing this? You know how I am approaching this, okay? I can guarantee you this, the next exam will not be, every exam is different. And I can reword the 6 green questions differently because they're applications to what's important, okay? And if I say I'm going to have X number of questions from an article, that's exactly what I'll do, okay? So on week 8, if you were there, if someone's there. Okay, there is something about an article, right?
Yep.
Okay, I want you to read the article because it has to do with your next project. Now, you read the summary at the beginning and the important points at the end. Complications of said LSTV. What's an LSTV? Lumbosacral transitional segment. What does that mean?
Just depend, yeah.
It's a normal variant. Your L5 is different than anybody else's. It has unique characteristics, okay? When we say 6 vertebral bodies, we say lumbarization. When we say sacralization, we mean 4. Now your L5 vertebral body is different, okay? And the article talks about a classification system. I'm not interested in you knowing the Castelvi classification system. I'm interested in you knowing the complications of what happens when we have an LSTV, okay?
Got it.
So I don't want you to spend any more time than to read the summary at the beginning and the complications at the end. That's what the project is. The other thing that's loaded up in week 8 is factor sheet, correct?
Yeah.
Okay, you might as well open that up, because after, we're gonna take a break, and we can get into that. Okay?
Yep.
All right, stretch, lights please.